Now the last presentation is on overcoming the challenges presented by radically increased student numbers in specialist community public health nurses. We are having very diverse topics, but all related to our areas of interest. I'm glad to introduce Ms. Amanda Drye, Senior Lecturer and Specialist Community Public Health Nurse at the Anglia Ruskin University. She is a very experienced public health nurse. She's worked both in the NHS and in the armed services setup, and she has a master's degree, interestingly, in ethics, politics, and public policy. I must say, Amanda, my memories go back to 40 years ago, when soon after, as a registrar in pediatrics, I opted for a year in field research, and that was on a survey of post-neonatal mortality in UK, and one of the centers was Newcastle upon Tyne, and my partner was the health visitor. You see, we visited all the children who died suddenly. The homes of the children where a sudden death occurred. So I look forward to your presentation.
Good afternoon. I'm honoured to have been invited here to this conference today, and how lovely it is to see you all, and hopefully we'll be able to share some of our own knowledge and experience in practice with you. First of all, I'm going to start with a few slides of Chelmsford and Cambridge, which is where the Anglia Ruskin University is based. Can I start this on? Excuse me. Okay, so this is the region of England. It's the east of England, and you can see the two areas, Cambridge and Chelmsford. These are buildings in the Chelmsford campus. As you can see, it's quite large, quite bio-friendly. This is Chelmsford city centre. Chelmsford is in Essex. These are some shots from the Cambridge campus, and these are shots of Cambridge itself. You can see the market in the left lower right corner. So we have over 32,000 students across all the faculties, across the whole university. We have 2,200 overseas students from over 120 countries, 2,700 staff, 16% of the market share in the east of England, and a high employability of graduates. 93% go on to work or further study within 6 months. The highest employment rate in the region. So my presentation today then is about overcoming the challenges presented by radically increased student numbers of specialist community public health nurses, as you so rightly say, Mr. Chair, health visitors. However, public health nurses are also school nurses. The school nurses deal from the 5 to 19 age group, and the health visitors deal with children from 0 to 5, and now we actually take on care during pregnancy, which is a return to old-fashioned ways. So, in order to lay the foundation of a health visitor and what it might mean to you, I have looked into your health system a little, and I think you have public health midwives, and the role is certainly similar. But all health visitors are not midwives in England.
But we have public health nurses.
But you have public health nurses. Lovely. Well, hopefully those numbers will grow. So a bit about the role of the health visitor. It started first in the northwest of England in 1862. And the programme of education started in 1892. So the course content at this time, and this was by 1916, it included elementary physiology, as you can see, methods of artisan cookery and household management, hygiene, infections and communicable diseases, and maternity, infant and child welfare, plus elementary economics and social problems. And to be honest, the role hasn't changed that much today in the new role that we're providing. So in 1929 it became a statutory service, and that meant every family was entitled to have a health visitor visit when they had a child. And that was a mandatory requirement. They could tell us to go away if we had turned up at the house, but they were entitled to that service. But by 1956, the service was provided from cradle to grave. So that meant health visitors at that time visited anybody that was needing. So the infirm, the elderly, those with chronic diseases, and young babies as well. Unfortunately, as the children's need became greater and the health visiting numbers dropped, the role then became directed more at children, again, 0 to 5 within families. And until 1994, a midwifery qualification was absolutely essential before moving into health visiting. And that stopped in 1994, and myself, I have an intensive care background. So in 2004, there was a big change with our the Nursing and Midwifery Council, and they brought in the public health standards for education. At this point, the health visitor numbers were falling due to lack of robust evidence to support their work, leading to disinvestment of the workforce. And what this meant is we knew we did a good job, and we knew that what we did was well received, but we didn't really evidence that well. We wrote in our notes and we wrote stories, but it really wasn't good, robust evidence. And so what happened was government policy decided to start reducing the numbers of health visitors because there was no proof that we made any difference. So in 2009, we put together as a group, and it was funded by the Department of Health, the Healthy Child Programme. And this was a programme, a core programme and service which should be available for all children from 0 to 19. And then they realised they didn't actually have enough practitioners to provide this service to all people. So it was an evidence-based document. It supported health visiting practice, and it was a result of increased identification of child abuse and diminished school readiness. So to put that in context, quite recently in Essex, 48% of the children weren't ready for school at the age of 5 years old, and in a developed country, that's quite significant. So we had advances in neuroscience as well and genetics, and we understood better how early childhood could be promoted and could be damage could occur later in life. And this was dependent on the interventions that we put in the early years. The service delivery at this point is the perspective of the community. A service is provided in the community and to needs within that community. It's a universal service and a home visiting assessment with a number of other specific contact patterns, and these are delivered to all families with children under 5. The categories that we use is universal, universal plus, and universal partnership plus, and the thread going through this is a community service. But we knew that we couldn't provide this service without doubling the number of health visitors. So we actually doubled the number of health visitors between 2011, and it really kicked in 2012, and the project finishes in 2015. That's 4,200 health visitors in addition to those that already existed. That caused a massive impact, as you can imagine, on education in practice, and on the practitioners themselves. So what the Healthy Child Programme set out to do was give a good, strong parent-child attachment, and we know with reference to Bowlby that attachment is incredibly important early on in life, and to give care that helps to keep children healthy and safe, and prevention of ill health. We wanted to encourage healthy eating and to increase activity, leading to a reduction in obesity, which is a huge problem within children now, and it's a growing problem. Prevention of some serious and communicable diseases, and increased rates of initiation and continuation of breastfeeding, which in the UK is very poor. We've increased the initiation of breastfeeding, but our elongation of breastfeeding still lies at a very low percent. We wanted to improve school readiness, early recognition of growth disorders and risk factors for obesity, and the early detection of and action to address developmental delay. And we'd also noticed that children's developmental problems had been missed because of the lack of contact within the health visiting service. The service had become one that literally managed safeguarding and child protection and wasn't able to do much else other than visit a family for an assessment.